Specialty Learning Outcome 7. In that part 2, we are continuing from the previous class, so it is a part 2. In this class, we'll be mainly discussing about child safeguarding followed by questions from the previous exams. Child abuse. Child abuse can be different types. It can be a physical abuse, it can be sexual, it can be emotional, it can be a neglect. Each one of these will be seen. And child abuse, if it is a physical, sexual, or emotional, or neglect, what are the risk factors? It is very commonly seen in first child born. If the child is disabled child or the parents have suffered in their childhood child abuse, it is an unplanned child what they had. It's unwanted. They didn't wanted a child, and it's an unfortunate pregnancy what they had and resulted in an unwanted child. A substance or alcohol misuse within the home, mental health issues. Either anyone who cares about the kid has an mental health issues. There's already a domestic violence which is going on, especially between the parents. Infant known to the social services or looked after the child. Especially these 4 points has been stressed a lot, especially in the RCAM new guidelines which have come up in October 2024. So what and all we are studying about the child abuse or the child safeguarding, it's according to the RCAM October 2024 guidelines. This is the latest guidelines which have appeared on the October of this month. Child abuse is also known as non-accidental injury. Don't get confused. They are the one and the same thing. So each one of this we are seeing now. First, we are seeing the physical. Physical abuse can result in bruising. When do we suspect if there is a bruise present? When do we suspect it might be a non-accidental injury? Whenever it is on the unusual sides. For example, on the medial aspect of the arms or the thigh, if it is present, it is unusual to get a bruise over the medial aspect. On the lateral aspect, it is very common because it is exposed to the surroundings. Bruising in a child who is non-mobile. Child cannot walk. How did it fall and have it? It cannot fall if it cannot walk. That's the logic what we are using behind it. If the multiple bruises are there of different ages, it is not very much suggestive. It becomes a little bit difficult if the child is mobile, if the child is walking around, because a toddler can be walking around and falling multiple times, might have multiple bruises which are healing at different stages. So you need to be a little bit careful here, but it is also kind of suggestive of non-accidental injury. Uncommon injuries which are bilateral, which is suggestive of certain objects like belt, the marking, the bruising, which appears like a belt mark or a stick mark or a finger imprinting. Someone has held the arm or the leg really hard, resulting in finger imprinting. Or sometimes it might be a human bite mark, especially you need to think of human bite mark if the bite, the penetrating bite, what you're seeing, if the canines is more than 3 centimeters apart, they are. If PTKs are present on the face, it might be a non-accidental injury. It might be because during violent cough or during vomiting, that is forceful vomiting, the patient still can have PTK. It might not be a non-accidental injury, so you need to be careful in that regards. Fractures, physical abuse can result in a fracture. If fracture is there, you need to admit them because it will be unsafe discharge for you. You need to admit the patient because you need to keep the patient, the kid in a safe environment. Multiple fractures are different ages of healing. Rib and spinal fractures, they're quite specific. The most specific one is the metaphyseal chip fractures. The most common one is long bone fractures, especially in less than 3 months old. Most common one. Fractures in infants who are not independently mobile, who cannot walk, if they have a fracture, it should highly alert you thinking that it should be a non-accidental injury. People get confused here. The common is, remember that it is a long bone fracture. That is nothing but femur fracture what we are talking about. Most suggestive of, if this fracture is present, it is very, very likely that it is a non-accidental injury. This is basically metaphyseal chip fracture. So there is a differentiation. Common means very commonly seen. Which fracture in a non-accidental injury? It is femur. But which is the most suggestive of a non-accidental injury if it is present? That is an epiphyseal chip fracture followed by spinal or a rib fracture. Head injuries can be present when you hold the kid and move the kid violently, can result in adrenal hemorrhages. It is very commonly found in kids. Occipital skull fractures when you drop the kid wantedly can result in, there might be multiple wide communicating fractures also might be present. Subdural hematoma in an infant or a toddler, you need to really think about, can it be a non-accidental injury? Wounds and burns. Torn furniculum is very much suggestive of, this is the furniculum which is known as torn furniculum, is very much suggestive of an non-accidental injury. Keep that in mind. Any injuries around the perineal or anything which is suggestive of a cigarette burn, like a small deep circular burns. These are all suggestive of a cigarette burn. Someone has tried to use the cigarette to burn or induce a burn on the kid. Sometimes they might dip the kid into an hot water. At hot water, if they are dipping a kid, usually they have kind of stalking kind of burns over the hand, lower limbs, buttocks, you can find it. And also the parts of the buttocks might be spared sometimes if they come in contact with the bath itself. For that reason, you need to be aware of. But whenever there is a stocking or a glove kind of burns are present, always suspect it might be a non-accidental injury. Neglect. Neglect is basically they do not care about the kid at all. Two things usually in neglect you should be worried about. Usually they don't care about the personal hygiene also. Because of the poor personal hygiene, the kid might be very dirty, unkept. And they'll be not worried about the child nutrition at all. They might be not feeding the kid at all. So underweight, under high, below the third percentile height, underweight these kids might be. So you need to be aware of whenever the underweight or an under third percentile, if the height is present, there must be something wrong here. There might be neglect involved here. Developmental milestones will be delayed when there is nutritional deficiency and personal hygiene is not taken care of. That will result in recurrent infections. Emotional abuse. Emotional abuse, most of the time, the parents or the caregivers are very critical about the kid here. They say you're a waste kid, you're good for nothing, you're not good, you're not scoring well in your school. They create an hostile environment. Sometimes they may not be concerned at all, but most of the time it is a critical and hostile environment. Because of the critical and hostile environment, there will be some personality and behavior changes you might start seeing in those patients. Sleep disturbances might be there. They might, after potty training, they might start soiling themselves. So they are going retrograde in their development. They might be having nocturnal aneurysm. This basically they wee during their night time and they are asleep. Sexual abuse. Sexual abuse is also very common. Now, non-accidental injuries. You need to really suspect about sexual abuse whenever there is bruising on the inner thigh, which is very specific for sexual abuse. Sexual abuse doesn't require it should be in penetration. Without a penetration, also it is considered to be in sexual abuse. Injuries to any genital, anus, vaginal genitals, any genitals and anal region, you need to suspect. Any perineal pain, discharge, bleeding, behavioral changes, you need to start suspecting, especially if they have inappropriate sexual behavior in a very young kid, 2 years, 3 years old, inappropriate sexual behavior, inappropriate sexual knowledge they are having at the age of 3, 4, 5 years, you need to start suspecting there might be an underlying sexual abuse there. There might be sexually transmitted diseases in an as young as 6, 7 years old kids. You need to start thinking, can it be in sexual abuse? Because highly unlikely to have a sexually transmitted disease in this young child. There might be unwanted pregnancies, especially in the teenagers around 12, 13, 14 years of age group. Recurrent urinary tract infections, though commonly seen in females due to poor hygiene, you need to keep in your mind, can it be in sexual abuse, which is resulting in an urinary tract infections in these females or in anyone in males? Whenever you come across a kid who has a non-accidental injury, that means a child abuse. It might be a physical abuse, it might be a neglect, it might be a sexual abuse. You shouldn't assume that there is a non-accidental injury. You shouldn't assume. You should keep your mind open. Do not believe anyone. Do not believe the mom. Do not believe the father. Do not believe anyone who is there. Take an appropriate, thorough history. Do a complete examination. That is what expected of you. Check everything. Check everything in the sense they want to strip the kit or remove all the clothes and completely examine the kit. Especially in infants, the incidences are as high as 75%. 75% of the non-accidental injuries are seen in infants. So the latest RCAM guidelines stresses a lot on saying that experienced clinical physician should see the infant before it is being discharged from the emergency department. Who is the experienced clinical physician? Anyone at the level of ST4. That is you. You are the registrar. You're giving this exam at a registrar level. So anyone at that level, at least that level, above that level, like a consultant, should see the infants before they have been discharged. So what you will do, when you're suspecting here, what you'll do, get a thorough history. Examine with complete external exposure. Then question yourself, is the observed injury consistent with the mechanism given? What is the mechanism are they giving? Does it correlate with the developmental age of the infant? Are there any additional risk factors present? These are the four risk factors where they want you to concentrate. That is the substance or alcohol misuse, any mental health issues in the carers, any domestic violence is present, or infant is known for social services because previously also the kid had a non-accidental injury or possibly had a non-accidental injury. So this many three things you will be asking. So again, you'll be gathering more information because the risk factors itself you may not be knowing. How do you know that they are aware for the social services? Previously, they had a non-accidental injury. Contact the social services. Contact the safeguarding team who is present. Contact the health visitors. Even police might be required. There might be some impending cases might be there. Old hospital records you might be seeing. Sometimes you might have to go through the child safeguarding information system which is available online. So you need to gather all possible information before you make a judgment. Now the guideline says that as you are at ST4 level, that means you should make a decision what next to be done. Before they used to do always consult the consultant pediatrician and take a call what next to be done. Here they want you to take a call what next to be done. That is whether you want to involve the social services, also nothing but safeguarding. Do not get confused. Safeguarding or social services, one of these terminologies will be used in your options. Or whether you will be just filling up the multi-agency referral forms or you will be informing the police. How to take in judgment. You inform the police if there is immediate threat for life or immediate threat for the injuries or there is immediate some risk involved for the kid. When is it? There is one particular situation where you need to think of it. For example, a parent's mom has brought the kid, you're suspecting a non-accidental injury, mom has taken the kid and left the emergency department. At that point of time, there is a high risk for even life of the kid. So you need to immediately inform the police at that point of time. That is the only circumstances where you'll be informing the police. No, the mom is cooperative, wants to cooperate with you and go ahead. Then you will be seeing the history is very obvious about the history is very obvious about the non-accidental injury because it doesn't fit in the history what they are giving. The mechanism of injury doesn't fit in. It doesn't correlate with the developmental stage of the infant. So you are really worried about the non-accidental injury. So you will either involve the social services as step one. Okay. In same terminology is safeguarding. So either one of those terminologies you'll be using or given in the options, choose that one. Once you involve, the kid should be in a safe place. If it's a morning time, for example, 9 to 5, they are presented. At that point of time, social services might come in. They might be able to arrange a safe place. For example, relatives' place, they might be able to arrange a place to stay in. Sometimes they might present in a midnight. Midnight, social services might not be readily available. If available also, they may not be able to find a place of safety. At that point of time, you need to go ahead and admit. So this admission is step 2 for you. So involving the social services or safeguarding team is the step 1. Step 2 is admitting the team as an place of safety, not for any evaluation or not for doing anything else, just as a place for safety. When do we choose multi-agency referral form? You feel that there is an injury which is not quite significant. For example, there is a bruise over the forehead which is present. Mom says 3 months old has rolled over and has a small bruise. It might be possible. A 3 years old kid might roll over and have an injury to the forehead from a cut and resulting in a small bruise. But you cannot be 100% sure here because development at the 3 months, 4 months might be rolling, might not be rolling. At 6 months, you're definite that rollover will be there. So at that point of time, when you are in doubt, what you do is you fill up a multi-agency referral form, which will include multiple agencies so that they will go through the scenario, they'll visit the home and take a call what next to be done. As it is a minor injury, as you are not strongly suspecting, you are happy to discharge this patient. So these are the three ways you need to choose the options in your examination. One question will definitely appear on this in your exam. Additionally, what else you need to be aware of? You need to you need to inform the parents and person accompanying the kids about the concern what you're having. What is the concern? It is the non-accidental injury concern what you're having. You need to discuss with them. You're not just involving the social services or safeguarding the kid and admitting without talking to the parents or without talking to the person who is accompanying the kid here. So you need to talk to them, explain them what is going on because they might not be involved in this non-accidental injury. They want to know what exactly is going on. So you need to have a good conversation with them. And it's very important to find out, are there any other kids? If there are another kids, That means if this kid has a non-accidental injury, that kid is also at risk of having a non-accidental injury. If you're doing and safeguarding for this kid, that kid also will require and safeguarding to be done. For that reason, you should always ask for, is there any other kid at home or not? Female genital mutilation. Female genital mutilation is illegal in UK. What is female genital mutilation? It's a procedure where they basically cut the female genitals itself. Okay, they might cut it or injure it or change the anatomy there. There is no medical reason for this. They do it as a ritual, which is very commonly done between this age where they're around the 15 years where they attain the puberty. So 12 to 15 years is the common age where they'll be doing it more commonly. It is, as I said earlier itself, it is illegal. As it is illegal, it is mandatory. You need to inform the police immediately. So you are not waiting. The first step always here, whenever you're suspecting an female genital mutilation, is to immediately involve the police because it is illegal. It shouldn't be done. This female genital mutilation is usually very painful and it usually affects their health. Even they might have long-term problems with the sexual activities. Even with childbirth, they might have issues, and it might be quite traumatizing for the patients. It is a mental trauma the kid might be having because of this female genital mutilation. So it is highly illegal in UK, and the first step is to involve the police, what the guideline says. This is a general topic. What I want to bring across is the father entitled to know about the admission if he still has the parental rights? Absolutely, yes. Yes, he has the rights to know. Usually father, the biological father I'm talking about, will have the rights, always will have the rights, unless the rights have been taken over or rights have been removed by the court. If the court has removed the rights, for example, because he has remarried or he has adopted a kid, they are divorced, at that point of time, if the court has removed the rights, then only the father cannot ask for the well-being of the kid or cannot ask about the admission or cannot ask about the child's health. Otherwise, he has the right. Mother always has the right. Doesn't matter what, biological mother always has the right to know about the kid. Complaints. Whenever there is a complaint, there are three levels of escalation. One is a DATIS. DATIS can be done for simple things. For example, someone has absconded. So you will do an DATIS. That is nothing but incident reporting. It is also known as incident reporting. So you're reporting the incident. There might be there might be an needle prick injury. You do an incident reporting. Level 2 is there is a serious incident. We call it as a serious incident where a patient is at risk. There is something happened to the patient because of something abnormal, something you are supposed to do it and you didn't do it, resulted in patient safe harm to the patient or resulted in something which causes concern to the patient. Then we take it as a serious incident. Never events have been clearly described which are the never events. Never events are the one where you have misselected the potassium strength and given to the person. Okay, potassium infusion, you want to give it 40 millimoles, ended up giving 80 millimoles, resulted in taking arrhythmias. That is taken as a never event. It should have never happened. So never event, it shouldn't have never ever happened. Administration of a medication in a wrong route. For example, you wanted to give patient subcutaneous 10 units of human actrapid, ended up giving intravenous human actrapid, might result in hypoglycemia, even might result in death also. Those are never events, shouldn't have ever happened. Overdose of insulin because incorrect device you have used or abbreviations you have used, then also it is a never event. Overdose of methotrexate for non-cancer treatments. Remember, it's a non-cancer treatments. Misselection of high-strength midazolam, especially in conscious sedation. Nowadays, we are not using midazolam at all for this reason. So these are all medication related. What are general ones? General ones are more related to nursing stuff, but you need to be aware of. Chest or neck entrapment in the bed rails, which can happen. If someone is very agitated, he's a dementia patient, and he can put his neck into the bed rails, or just might have got trapped. That safety should be taken care of. We should be aware that this patient is very agitated. He can do anything. He is a dementia patient. So that needs to be recorded and the safety should be taken care of. Transfusion of ABO incompatibility blood components. Someone is B positive, you ended up giving an A positive blood group, can result in disaster. Intravascular hemolysis can result. Intravascular hemolysis usually carries a very high mortality rate. Misplacement of nasopharynx, oropharynx tubes. Okay, misplaced it. Basically, you wanted to place it in the stomach, in the GI tract, into the stomach, ended up placing into the trachea. That is also considered as a never event. Scalding of the patients can result, but it is a rare entity. Basically, burns what we are talking about. It's a rare thing to happen. Unintentional connection of a patient requiring oxygen to an airflow meter. Airflow meter port looks very much similar to that of the oxygen port. They should be very much aware of. Usually labeling will be done in the NHS so that there is no confusion. If you unfortunately connect to a patient to an airflow meter instead of an oxygen, that might result, sorry, that might, should be, sorry, that should be considered as a never event. Undetected esophageal intubations. It was considered. Now they have temporarily suspended it as a never event. So you need to be aware of these are all never events who should never ever should have happened. So this is considered as in level 3. Level 1 is something which is very commonly happens and patient is not at risk. Patient at risk, but it is not a never event, then it is a level 2. These are the complaints what you need to be aware of. Fit notes. Someone might can come here, also known as leave note. Patient himself can declare for 7 days of absence. I am sick, I am having gastroenteritis, so I cannot come for 3 days, 4 days. He can self-claim with himself in the UK. If it is more than 7 days of absence, you feel he needs to take rest for 1 week, more than a 1 week's time. At that point of time, you need to provide them an MET3 certificate. You as an emergency physician also can provide this MET3 certificate if there is anything suggestive of requiring a long duration of away from the work. For example, he is an sorry, he has an very bad what you can call it low back pain, and his work is lifting heavy objects. So you need to be away from lifting heavy objects at least for a couple of weeks. Then you need to give him a MET3 certificate for that patient. So in those circumstances, you can give as an emergency physician MET3 certificate if they request for. For less than 7 days, you can just tell them that you can self-declare yourself. No medical certificate is required. This stands for medical certificate, MET3 certificate, specifically we call it as. Before we go into the recall questions, if anyone has doubts, we'll go through it. If FMG done outside the UK but later presented with an wound, infection, pain, or UTI complaining after a few days, this also needs to be informed to the police. Absolutely, yes, you need to inform it to the fearless. FMG done anywhere in the world, you are in the UK. So UK, accordingly, it is illegal. Doesn't matter where you have got it done. So whenever you're going through the SLO questions, holds good for other questions also, but specifically for the SLO questions, strictly follow the guidelines what we have discussed. These are the guidelines either given by the NICE or by the RCAP. So you're not deviating from the guidelines. Someone has their own issues. Some consultant comes and says, according to my experience, you need to do this. Experience, what they come and say is at the lower part of the pyramid. That means it doesn't carry any value compared to the guidelines. Guidelines is the tip of the iceberg, what you're seeing it. That means tip of the pyramid it is. So it carries the most importance. So guidelines should be given importance. You need to stick to the guidelines, which someone comes with an experience and tells you and all doesn't hold good. So guidelines has the utmost importance. You need to stick to it. If you do not stick to it, that answer will be wrong. They will not give you any mark. You are you are in the department where teamwork matters a lot. So you need to help out your colleagues in however possible you're helping it out. So whenever you're answering an SLO 7 questions, you are super nice person. If you're a super nice person, what you will be doing? So if I'm a very good saint kind of a person, I'll be doing this. That should be the right answer, or that will be the right answer. If the circumstances comes and where you need to say that you've done something mistake, then you have to tell, yes, I have done the mistake, and you have to agree to the mistake what you have, or agree to the inabilities what you're having. For example, you're not good at intubation. You need to tell, I do not know how to intubate. Please teach me how to intubate. I cannot just intubate. I never done an intubation. You should be frank. Consultant might come and intubate that patient. No, you should tell them, I don't know how to intubate. You will not go there and blindly try doing because I've seen some YouTube. That is the wrong way. You're putting the patient's safety at risk at that point of time. Someone presents with a self-harm or depression. Okay, we usually use an sad person score to discharge. Most of the time, sad person score completely information might not be given. So look for whether there is any suicidal ideation is there. If there is no suicidal ideation, if a self-harm, it has come a small lacerated wound, I don't feel like killing myself, I feel completely all right myself, then you can discharge them and ask them to follow up with the mental health team. With the psychiatrist, you can ask them to follow up. If that is not given in the options, you can ask them to follow up with a general practitioner. Remember that take and consent, if they do not have a capacity, the next step is to look for lasting power of attorney or AD. You will be looking out for whichever is the latest one, you will be using it. If that is not present, then you will be treating the patient in the best interest. Once you are chosen, do not change the answer unless you have a good reason to do it. Because these are all SLO 7. Is there anything new? The guideline, I remember the guideline, the child abuse guideline, the flow chart, I can recall it now. Then you change it. I cannot recall anything about this one. Let me think. Let me use a logic. That will always be wrong. Do not change your answer what you have picked it up. Do not overthink for the questions what you are having. Keep it very simple. If you overthink, you'll get it wrong. If you're marked and you come back and you're seeing the same question, do not change it unless you remember something which has a good reason for you to change it. I remember a guideline, then you change it. I don't remember anything. I'm using my own logic. It will definitely wrong if you change the question or the answer at that point of time. Keep all these tips in your mind when you're answering the SLO 7 questions. SLO 7 questions are tricky, but if you keep these points in your mind, it should be a smooth cakewalk. Out of 15 questions, you should be easily, I'm saying easily because of the recall questions also will be appearing. Easily, you should be able to score minimum of 12 out of 15 should be easy. This should be the scoring place for you to score 12 marks here itself. 3 marks might go off because a new question has popped up, a new topic has popped up, you're not aware of it. It's okay. You should be able to get 12 marks out of 15 definitely in the exam with the information what I have given here. So we'll go with the first question what we are having here. The first question here is you're leading an trauma case of multi-casualty of a road traffic accident. You have a patient who has a blunt abdominal trauma and lost cardiac output 45 minutes ago. The surgical registrar wants to perform a resuscitative thoracotomy while you are against it. Your consultant is busy intubating a child from the same accident and he is not to be disturbed. What will you do at this point of time? What you will be doing? So what does the guideline says? We are going back to what we have learned from the guidelines. Guideline says is you are not directly jumping to a resuscitative thoracotomy unless you have done a finger thoracotomy and that is unsuccessful and the patient has presented within 15 minutes of penetrating trauma. This is a long time what you are having. It's not been 15, it's been more than 15 minutes. It should be less than 15 minutes after an penetrating trauma. For a blunt trauma, it should be less than 10 minutes. For this situation, it is less than 10 minutes. It is 45 minutes. So there is no indication to do an resuscitative thoracotomy. So you are the team leader. You are the boss in the emergency department. You are taking care. So all other specialties who are coming, doesn't matter what grade they are. Once you are in the trauma, you are the boss. You are leading the trauma team. So what you need to do, you need to override the surgical registrar here. Continue registrar until the consultation is free. No, not required. Overriding the surgical registrar. You need to take the authority thing here and override the surgical registrar. You're not agreeing for thoracotomy. Discuss with your team. No, doesn't make sense here. Request surgical registrar to take over the team leader role. No, that basically implies that you're not competent enough. Here, they're expecting you to be confident enough to take over the leadership role. A 80 years old female presents to the emergency department with complaints of burning sensation and increased frequency of maturation. On examination, she is hemodynamically stable. You notice multiple contusions over the lower abdomen and thigh. Her son is her caretaker. Urine analysis shows infection. You prescribe oral antibiotics. What is the most appropriate next step in the management? First, always think of the medical part. Then only you're thinking about the social part or SLO 7 part, what you'll be thinking. First, the medical part, what we are thinking about. So this patient is hemodynamically stable. Suggestion of urinary tract infection, you prescribe the oral antibiotics. So you can discharge this patient safely. No issues with those regards. Coming to the next part of it, there are multiple contusions over the lower abdomen and thigh in an elderly. So elderly abuse might be present. Ideally, what we do? We talk to the elderly person here and we discuss whether you want to involve the safeguarding or not. You want the safeguarding team to be involved or not. That is basically social services to be involved or not. That next step is not given here. So we will go behind here. As this is suspected of a non-accidental injury, it's better to discharge with the social services to home. Much better admission would have been just admitted this patient. That would have been just much better option. Here, admission is given, but for IV antibiotics, no, you're not admitting for IV antibiotics. For skeletal survey, no, you're not admitting for this patient for a skeletal survey also. We are not doing a skeletal survey anymore here. Arrest the patients. We do not know. We are just suspecting a non-accidental injury. We do not know what the hell has happened. Follow up with the GP. It might be a high risk for this patient. That's why we are selecting discharge with social services services to home. A 6 months old baby was brought to the MS department by his mother with complaints of continuous crying. The baby was with the mother's boyfriend since morning. When the mother came back home from work, the baby was crying continuously. On examination, you find multiple bruises on the baby's body. You suspect and child abuse. What is the most common site of fracture in such patients? Common, they are asking. Common means long bones. That's basically femur. A 4 months old baby was brought to the ED by his mom. Mom complains that the baby is crying continuously and she is unable to console her. You notice a bruise over the right arm. Painkillers are administered according to the local protocol. X-ray of the right arm shows a fracture of the shaft of the humerus. You strongly suspect a non-accidental injury. What is the reason for your strong suspicion? Why are you suspecting in a 4 months old a non-accidental injury after having an humerus fracture? We are suspecting because the kid is immobile at this point of time, cannot walk at 4 months age. How did it had an fracture? That is a fracture, complete fracture of a long bone, humerus fracture is there. That should be highly suspicious of a non-accidental injury. One of the one of your junior doctors discusses a case with you. He's a 78 years old male, a known case of CA lungs with metastasis. He is dependent on others for daily activities. You decide that the best course of action for the patient is palliative care with DNR. Which of the following advice will you be giving to the junior doctor regarding the DNR? Complete the DNR on the system. Yes, he needs to complete it. Let's see more appropriate options are there. Complete the DNR and inform the family. This is also kind of correct. Yes, you need to inform, not the family, the patient you need to inform. Okay, if the patient doesn't have the capacity at that point of time, we usually inform the next of the kin. Let the other team take over the decision. This is absolutely wrong. Your patient in the emergency department, you need to take the call. Allow the patient and relatives to decide on DNR? No. DNR decision is taken by the emergency physician or by the doctor. It's not a decision taken by the patient. Complete the DNR, involve the patient, get the second opinion if he disagrees. This covers everything about the palliative care with DNR. So this is the most appropriate, most correct option here compared to rest of the options. It might be partially correct this one, but most correct one is the fourth one. You need to always select which is the most correct option. A 3 months old baby was brought to the emergency department by the mother and her partner. There is a history of baby rolling over of the changing table and sustaining an injury to the right upper limb. X-ray shows and right humerus fracture. The orthopedics have reviewed the patient and appropriate treatment has been administered. What is the most appropriate next step here? What you will be doing for this patient next step here? So are we strongly suspecting a non-accidental injury? That should be the first question. A 3 months old having a right femur fracture, that is a major injury. We need to suspect it as a non-accidental injury because 3 months old babies are usually not rollover, wouldn't have come by this rolling off the changing table. It's unlikely to happen at 3 months of age group. So what you'll be doing? So because you're strongly suspecting a non-accidental injury. I see most of you are getting wrong here answers. Why you want to get and fill multi-agency referral form? You are not doing this because you're not you are not doing this because you're strongly suspecting non-accidental injury. You do it when you're not strongly suspecting a non-accidental injury. When you're suspecting strongly a non-accidental injury, the first step is to involve the social services. The second step is, as in place of safety, you can admit into the pediatric ward. So the fourth one should be the most appropriate answer. Again, second one is not the admission. Why you want to admit this patient? First is involve the social services. If the social services cannot place this baby in a place of safety, then only you will admit the kid. Arrest the mother because we do not know what has happened. Inform the police. You'll be informing if the mother with the kid has left the department. A 13 years old female came to the ED with a significant overdose of paracetamol. Paracetamol levels are above the treatment line after 4 hours of ingestion, and she is a known to child and adolescent mental health, simply known as CAMPS, very frequently used this short form. So remember, CAMPS means child adolescent mental health, who will be attending the ED in 2 hours. The patient is refusing treatment, wants to leave. What is the next best step in the management of this patient? Here, what we want a consent from an patient so that you can start the treatment. First, coming to the consent itself, it's a 13 years age. 13 years age group is the age where glimic competency we check for. So, does this patient has an glimic competency or not? Doesn't matter. Why it doesn't matter? Because anyone, because an young adult cannot refuse an life-saving treatment. Here, giving an acetylcysteine for paracetamol overdose is a life-saving treatment. What you're doing, otherwise it might result in a liver failure and even in death. For that particular reason, this patient cannot refuse an life-saving treatment. If you cannot refuse it, then what you'll be doing next? You will treat it in the patient's best interest. What is the best interest for the patient? To start the NAC. He's uncooperative here. That's why you need to tranquilize the patient and start them on an acetylcysteine. So the right answer here is the third one. The police brought a patient who was involved in a motor vehicle collision to the emergency department. On arrival, the patient was received in the resuscitation bay, intubated, connected to the mechanical ventilator. Police has requested your registrar to take the blood sample. Your registrar has called you in the night asking for help. What advice will you give? You will tell them what your advice will be. If you are free, go ahead and collect the sample and give it to the constable because they're requesting. It is according to the Road Traffic Act. You can give it. It is a law what is there. Tell her not to involve another doctor. Absolutely wrong. Ask her not to do it. Again, wrong. Ask the police officer to bring in court order. Again, wrong. They cannot wait for a long time because alcohol levels fluctuates over the time. They might not be appearing in the serum at all if you delay it a lot. Ask her to do it. Yes, it's the most appropriate thing. Tell her to involve the guilty court guardian. Again, absolutely wrong here. A radiologist from your hospital called you on Friday evening at 6 p.m. regarding a child with an congenital hip dysplasia. The GP arranged an X-ray for the patient who is 3 years old and she has had a limp for last 3 weeks. You don't have a pediatrician or orthopedic in your hospital. So what advice will you give to the radiologist here? What advice you will be giving? Radiologist is the person who works in the closed doors. He just sees the X-ray. He picked up an X-ray and he feels that there is something seriously wrong here. Congenital hip dysplasia is here. You can see it is already dislocated also. X-ray has been already given. Hip is dislocated here. What you'll be doing for this? Radiologists and our colleagues help them out. So what you'll be doing? Ask him to shift the patient to the emergency department so that you can arrange an ambulance because you are in the emergency department, you know how to arrange the ambulance and you can shift to the nearest hospital. So second option will be the most appropriate one. Let us see why not the other options. Ask the patient to go back to the GP. No, it is not appropriate at all. Ask the radiologist to refer him to the nearest hospital with the pediatric and orthopedic facilities. Again, it is not appropriate at all because radiologists are not don't know how to arrange the ambulance. They do not have the contacts as we have in the emergency department. Inform him emergency department is busy, so don't send the patient to the AD, any. No, you cannot do that. You're being very rude to your colleague here. Tell him it is not an emergency, hence will not receive the patient. No, again, it is an emergency. Why it is not an emergency? It is a dislocated hip what you are having. Again, dislocated hip, you cannot send it to the GP. A 2 years old child was brought to the emergency department by his uncle. He complains that the kid has not been feeling well since a couple of days. His observations are within normal limits. The junior doctor has seen the patient in the minus and he suspects child abuse. Which one of the following may indicate physical abuse they are asking? Inner thigh abuses are more specific for sexual abuse. As we have learned, it is more specific for sexual abuse. Spiral fracture tibia. It is a normal finding commonly seen in toddlers. It can be seen. Toddler fracture. Yes, that's why it cannot be a spiral fracture or it is not very much suggestive. Poor eye contact. Any sick kid can have a poor eye contact. Continuously crying can be because of the pain itself. The kid might be having pain for different reasons. It's not suggestive of a non-accidental injury. Contusions of different ages on the shin. Yes, that is more suggestive of a non-accidental injury. So the option 3 is most likely one. A 2 years old child was brought to the MS department with a red sore in the chin area. The triage nurse has checked his vitals, which are within normal limits. The junior doctor suggests it might be a cigarette mark. You are consultant and you have received the patient. You think it is an impetigo. What will you do next? You are the consultant. You have made a diagnosis of impetigo. Treat it as impetigo. You are not thinking of a non-accidental injury. So what is the treatment for impetigo? Give physitic acid, then discharge this patient. None of the other things will be an appropriate thing here because you're not thinking of non-accidental injury itself. Impetigo gives an honeycomb appearance which can appear like a burn for a junior doctor, but you are an experienced one, can pick it up as an impetigo. You have picked it up here. You are just treating for the impetigo here. An agitated patient came to the ED with possible psychosis. He's irritated in the emergency department. The nurse informs you that he's threatening to leave the emergency department due to long wait. According to the guidelines, which one of the following is true regarding the physical restraint? They're just talking about the physical restraint here. Can the physical restraint can be done up to 20 minutes? Absolutely not, only 10 minutes. Physical restraint till you get help from the medical health team? No, that is also not correct. Physical restraint, if required, should be less than 10 minutes. Absolutely right one. Physical restraint and admit, no, you cannot again physical restraint for more than 10 minutes. Physical restraint till you, sorry, till you section him under the Mental Health Act. It might take longer than 10 minutes. There's no specific time here. So again, it is a wrong one. So the option third is the right one. A 15 years old girl present to the MS department with self-harm. On examination, a superficial lacerated wound is noted over the right forearm, which is clean and dressed. The patient seems to be in depression for bullying at school. She further adds that she has plans to go on a school trip next week. What is the most appropriate next step in the management of this patient? First thing always in this kind of patients is medical issue. Is the medical issue dealt? There is a lacerated wound which has been cleaned and dressed. Yes, the medical issue is addressed, so we can discharge this medically. Now coming to the other issues, the social reasons or the psychiatric issues what they are having. There is some amount of depression which has led to the lacerated wound because of the bullying. But she says she wants to go back to some school trip next week. Doesn't seem to be in severe depression here. She wants to go back to the school. She is happy with the go back to the school. Nowhere it has been mentioning that there is any suicidal ideation here. Keeping all this in mind doesn't require an immediate referral to the psychiatric team. They can follow up in the outpatients. So outpatient psychiatric team follow-up is the ideal option here. Immediate, admit immediately, no. GP for depression follow-up, this would have been the right option if this option was not present. As this option is present, this option is the wrong one here. Discharge with no follow-up, absolutely wrong. There is certain amount of depression is there. She needs to follow up. The depression might progress to a severe depression over the time. For that reason, follow-up is required. Section under the Mental Health Act, no. There is nothing here to section under the Mental Health Act because you do it section if you want an admission for further evaluation. Here, nothing is there suggestive of that. A 28 years old pregnant woman came to the ED with complaints of domestic violence. On examination, the patient is hemodynamically stable with few bruises over the body. Analgesia has been administered according to the local protocol. You raise a concern about the issue of the safeguarding team, issue to the safeguarding team, and then plan for a discharge. Before the patient leaves, what question will you ask her? The question what you need to ask her is, are there any children at home? If they are present, these children also need and compulsory safeguarding. This is according to the NICE guidelines. So this is the right answer. Ask about her partner, doesn't make sense. Ask her to place a police complaint. Her issues, you cannot force them to do it. Ask if she can stay at a place, friend's place. Again, it's her choice. She can do whatever she wants because nowhere here is suggestive of patient doesn't have the capacity. Ask if she is married. Again, doesn't make sense. So this is the most important question what you need to ask because if the child is present there, it requires and compulsory safeguarding for that kid. You are treating a 44 years old male who was involved in a road traffic accident. The patient is intubated and connected to the mechanical ventilator and shifted to the ICU. The police comes to the ED requesting the name and address of the patient suspected in a road traffic accident. What will you do at this point of time? In this point of time, you can give because it is a road traffic accident. According to the law, according to the Road Traffic Act itself, you can give the personal information. So give the minimal details what is required for the police. You can also give the injuries details if it is an sharp object or like a knife or it's a gunshot injury, you can give it. In road traffic accident, we do not give those informations. Rest of the options are wrong here. A 15 years old girl presents with a self-injury to the right thigh. On examination, you notice a lacerated wound over the thigh which doesn't require a closure. Hence, the wound was cleaned and dressed. You also notice multiple old self-injury scars over the wrist. The patient denies having any suicidal thoughts. So denies any having any suicidal thoughts is the important one. Camps are busy with another patient, hence it will take take time for them to assess. The patient is in the ED. She doesn't want to wait for the camps. What is the most appropriate next step? 15 years. 15 years, if they have glyc competency, you can discharge them because you're not suspecting anything which requires an admission. She can follow up on the OPD basis. So discharge if she has a glyc competence is the right answer here. Contact parents, no. If they have glyc competency, you can need not contact the parents. As she is a minor, she doesn't have the rights to refuse. Holds good for a life-saving or and limb-saving treatment. Here is nothing is that kind of thing. Physically restrain her, absolutely wrong here. You shouldn't be doing that. Sedate and admit her under camps, no, no, it's not required because there are no suicidal ideation. While working on an evening shift, you notice a 60 years old male in majors has suddenly become unresponsive. He was immediately moved to the races. On initial assessment. You found to have an BM of very low BM, 1.5 millimoles per liter. He was treated with an intravenous glucose and the patient recovered. You find a prescription for 10 units of human ectopit in his drug chart. On inquiry, the nurse confesses that the insulin was intended for the patient in the next cubicle. The wife has arrived to the ED and wants to know what has happened. Which one of the following statement is correct? Mild harm caused an informed wife as an duty of condom. It is not a mild thing. It is a hypoglycemia where an intervention was required. It is a never event which has happened. So this phrase is wrong. Moderate harm also, it is not a moderate harm, it is a never event. Datix the nurse, it is not a datix, it is a never event what you need to be aware of. No, it is not. Level 1 is the datix or incident reporting what you'll be doing. Severe harm caused and investigate the event but differ from the duty of condor until the investigation is completed. No, what is duty of condor? Duty of condor is your duty to inform what has exactly happened to the carers or to the next of kin. If they inquire for and there is no breach of confidentiality, then you need to inform exactly what has happened. So the fifth option is the most appropriate option here because it is a never event. You need to investigate why it has happened, where the errors were, what improvement you can do it. So audit will be required. Inform wife what exactly has happened. We unfortunately has given wrong dosing of human actrapid intravenously to a wrong patient, resulted in hypoglycemia. We are treated. So the option 5 is the most right answer here. So these are the never events what we already discussed for. You arrive for a morning shift. One of the nurses finish her shift, informs you that she overheard the FIO2 doctor using homophobic language towards somebody else. Homophobic language is absolutely no in the NHS or in the UK. You are the senior most doctor on the shift. What will you do? What you'll do if someone comes and complains? We'll take it as a very simple example. Like if the two kids are fighting with each other, what you'll be doing, or if the two kids are fighting with each other in a classroom, what the teacher will do, they'll talk to each of the kids separately and ask them what has happened, what made you to fight with the other kid. That's what exactly you need to do here. Also speak with the nurse and the doctor separately, ask them to provide the evidence of the episode and remind them about the NHS values. That's what you will be doing. That's what has happened. That's what is expected of you. So it's more often being a nice person, and which is the most appropriate out of the options what are present here, you will be selecting, rather than it is anything related to the guidelines per se. A mother brought her 9 years old son to the ED who was involved in a road traffic accident. The patient has received the patient, sorry, the patient was received in the recitation bay. He is in hemorrhagic shock requiring a blood transfusion. The mother refuses to give consent for blood transfusion as they are Genova witnesses. What is the most appropriate next step in the management of this patient? Genova witnesses is basically a belief that they shouldn't get any blood transfusion done from anyone else. So blood transfusion, they absolutely refuse for the blood transfusion. That is more often religious belief what they are having. It is a 9 years old son. So you need to take a consent from the carers. Those are the parents here. But parents are refusing. Here the blood transfusion is life-saving. So parents can only consent for the blood transfusion. They cannot refuse for the blood transfusion because it is life-saving. So you will inform the mother that you need to transfer the blood to save the life and transfuse the blood. So it will be the most appropriate one. Same thing we'll change a little bit and discuss more here. We will make this as a 19 years old and the patient is himself refuses for the blood transfusion and he is a genuine witness. That's why he refuses for the blood transfusion. What will be the right option at that point of time? At that point of time, do not transfuse the blood because he is an adult. He can refuse any treatment. So do not transfuse the blood at that point of time. A 20 years, sorry, two girls aged 15 years come to the emergency department with an alleged history of rape. On examination, no life-threatening injuries are noted. They are partying at a friend's place where an 18 years old guy gave them a drink and mostly raped them. They do not want to involve the police. What is the most appropriate management plan for the patient? The most important wordings here, what you need to pick up is no life-threatening injuries are there. That means no acute injuries are present. If no acute injuries are present in this patient, the best thing is to refer to the SARC, which stands for Sexual Assault Referral Center. So the most appropriate answer here is the second one. An HIV patient jumped out of a bridge, resulting in severe injuries. The patient is brought to the emergency department with ongoing CPR in an ambulance. On arrival, the patient is in cardiac arrest and the CPR is continued. After 20 minutes of CPR, the patient is declared dead. The police were involved. Which one of the following is a contraindication for organ donation? So basically, they're asking what is the contraindication for an organ donation. HIV can be donated to another HIV infected person. So it is a relative contraindication. Police involvement, no. Corona case, no. Active malignancy, absolutely yes. Alcoholic liver disease, no. No, 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 and no. Active malignancy, yes. So option 4 is the right answer here. A 6 months old baby was brought to the MS department by his mother with complaints of continuous crying and circumferential burns over the limbs. The baby was with the mother's boyfriend since morning. When the mother came back home from the work, the baby was continuously crying. After examining the kid, they suspect child abuse. What is the next step in management of this kid? Again, child abuse. We are strongly suspecting a child abuse. Whenever we are strongly suspecting a child abuse, first step is to involve the social services. Social services, sometimes in the options, they can give it as child safeguarding. So the right option here will be the first one for the child safeguarding, what you'll be doing. After child safeguarding, if there is no place of safety is present, you can admit this kid. Rest of the things will be carried over by the social services. This is according to the October 2024 RCAM guidelines, is the latest one which have come. A 70 years old Alzheimer's patient was brought to the emergency department by his grandson with an overdose of his medication. The patient has lost his wife and daughter. He keeps taking overdoses and doesn't want to live. He answers all your questions appropriately or properly. The grandson wants to treat him. What will you do? The first thing is, does the patient have the capacity? I say the patient doesn't have the capacity. Why do I say the patient doesn't have the capacity here? The main reason here is the patient is in grief. Why? He has lost his wife and daughter and wants to be with them, doesn't want to live. That means he is in severe depression. He is. Anyone who is in severe depression, we need to assume that he is not able to weigh the pros and cons. There are four things what you need to understand. What you need to remember is, one is he is able to understand, he is able to retain, weigh, and communicate back to you. In this, you can assume that the patient is not able to weigh because he is in severe depression here. So if the patient doesn't have the capacity, the next step is to look for if there is an LPA, AD, and see which one is the latest. So look for LPA and AD with the right option here, option number 4. If LPA and AD is not there, that's when we treat it in the patient's best interest. A middle-aged male was involved in a road traffic accident. He presented to the emergency department with the complaints of neck pain. On examination, there is no indication for the CT C-spine according to the Canadian C-spine rule. His brother is a consultant surgeon and he demands a CT scan. What will be your most appropriate action? You have followed the guidelines. NICE guidelines recommend that you need to follow the Canadian C-spine rule. Then if it is not required, it is not required. You are not wasting the NHS resources. Those are the government fundings. You are not unnecessarily getting any investigations done. So firmly say that CT scan is not required here. I'm not getting the CT scan done. This is my department. I have decided according to the NICE guideline, Canadian C-span rule, I have used it. It is not required and you're not getting the CT scan done in this individual. A 73 years old patient is brought to the MS department in a cardiac arrest with ongoing CPR. On arrival, CPR is continued. The nurse gets the advanced directive of the patient, which states the patient wants the DNR. But the doctor wants you to continue CPR. What will be your most appropriate action? Does the patient have the capacity? No, the patient doesn't have the capacity because he is in cardiac arrest. Then we'll be seeing LPA and AD. They are both are present. LPA and AD are present. Which one is the latest one for us? It is required. Latest one is the AD. The nurse gets the advantage to state that doesn't want the DNA, but the doctor wants you to continue CPR. Sorry, here there is no LPA, there is only AD which is present. There is no LPA is present, only AD is present. Only AD is present, so you need not see which one is the latest. You need to just follow what the AD says. The advanced directive says that says that to stop the CPR because he doesn't want, the advanced directive says, which states patient doesn't want the DNA. It is specifically mentioned. So do not hesitate. So you will stop the CPR and declare death once you confirm the things what are required to confirm the death. You're teaching a group of students who are rotating in the emergency department. The topic of teaching is DNA. Which one of the following is true regarding the DNA? The doctor makes the decision about the DNA according to the patient's current condition and relatives' wishes. No, not according to the relatives' wishes. DNA needs to be the patient decision. No, it is a doctor's decision. The doctor need not inform about the DNA to the patient. No, you need to inform to the patient. The doctor decides about the DNA. If the patient disagrees, then second opinion needs to be taken. Absolutely correct. The doctor decides about the DNA. If the patient disagrees, the DNA is invalid. Again, wrong. The DNA decision is taken by the doctor himself. 26 years old pregnant female present to the ED in active labor. There is no OBGYN available in your hospital. The nurse has received the patient in the resuscitation bay and has requested you assist the patient. On assessment, the cervix is dilated and the patient has contractions. What will be the next step in the management? As an emergency physician, it is expected of you to deliver at least a normal delivery. It looks like a normal delivery. In normal delivery, you just encourage the mother to push the baby out. That's it. Nothing else you'll be doing other than the cutting the cord. So deliver the baby in the emergency department, shifting to the other hospital or calling the nearest OBGYN or admit the patient under acute medicine or asking the husband to take the patient to the nearest hospital. Absolutely wrong. You are supposed to deliver this baby because this is one of the competencies they expect of you as an emergency physician. A 44 years old male, a known chronic alcoholic, arrived to the MS department with complaints of pain abdomen. Initially, he was seen by a student nurse in the triage area. After 2 hours of the arrival to the ED, you see the patient. He doesn't have any signs of life and is declared death. What will be the most appropriate action here? What you will do? The patient is dead. You went to the cubicle and he doesn't have life. He has died long time back and you declared the death also. Give handover to hand over the next day to the consultant. You are basically your responsibility you are handing over to another person, which is no, your responsibility is you need to take over the responsibilities. Complain to the senior nurse about the student nurse. Again, we don't know what student nurse are done. We can't just blame them. So again, it is not a very appropriate right answer. Request for postmortem. Postmortem, you do not request coroner request for the postmortem. So again, it is not an appropriate answer. Call the police for documentation and legal issues. Yes, this is correct. You need to call the police, might be required. Again, we are not sure what has happened. It is also not an appropriate option. We usually involve the coroner. Coroner takes over and sees what needs to be done. If required, he will involve the police. If required, he will get the postmortem done. Document all the events of the circumstances of the death. Yes, this is the most appropriate. Mainly what happens is whenever you are referring a case to the coroner, this case has to be referred to the coroner here. Whenever you're referring the case to the coroner, you need to provide them all the details when you're referring. So you need to tell by this time the patient had arrived and this nurse has seen. After seeing this nurse, I went and saw this patient at this point of time. Then there were no signs of life. I decided against doing a CPR because the patient was in rigor mortis. All those you will be, and you are declared death at this point of time. I'm not sure about, or I do not have any cause for the death. That's why I'm referring to you. So all these events, what has happened needs to be documented because it is required to refer to the coroner. So the most appropriate answer here is the third one. A 72 years old male was brought to the emergency department with a history of slip and fall. He sustained an injury to the right thigh. X-ray femur shows a shaft of femur fracture. The nurse complains that the patient is uncooperative and trying to remove the cannula. He also threatens to injure the staff. What will be the most appropriate action here? So this is basically an ABD presentation what you are having. If you do not confuse with the SLO what you are having, it's just an ABD presentation what he's having. He's threatening to injure your staff. Sedate him first, then continue with the treatment. Most likely what has happened here is whenever there is a fracture, femur fracture, severe pain will be there. Pain, especially in an elderly patient, can result in triggering dementia. Okay, so he might, sorry, not dementia, he can become delirious. Delirium can be triggered. So delirious here. He is delirious because of the pain. So if you can sedate him and give a good painkiller, or you can sedate him with the ketamine itself, which has an analgesic effect, the patient will get back to the normal senses. So the right answer here is the first one. A 6 years old Somalian girl was brought to the emergency department by her grandparents with a bleeding from the vagina. She denies any fever. Her vital parameters are within normal limits. On examination, the nurse notices blood in her underwear and she has poor eye contact. There were no previous visits to the hospital. What is the most appropriate diagnosis here? Somalian, whenever this word comes as in Somalian, okay, these are one category of people where they believe every female who attend their puberty, female genital mutilation should be done. It is more often religious belief. Whenever they mention Somalian, it is always a female genital mutilation for you. Along with it, with the bleeding at the vagina at the 6 years old age, you need to think about something is wrong. Here, because they have mentioned Somalian girl, you need to think of more often female genital mutilation rather than sexual abuse in this kid. What will be the next best step in this patient? You have the diagnosis. What will be the next best step? Next best step is to involve the police because it is illegal. It is mandatory to involve the police. So involving the police will be the next best step in this patient. A 23 years old, a 23 years old was involved in a road traffic accident, sustained an injury to the head. On examination, the left pupil is dilated and the right pupil is constricted. The patient has intubated and transferred to the CT scan. The CT head showed massive intracranial bleed with midnight shift. Neurosurgeons inform you that the patient is not for the surgical intervention. What is the most appropriate next step? Now we need to consider this. Is this a patient whom you can go ahead and consider this as a potential donor? Is he a potential donor? Potential donor, what we did, there is a catastrophic brain injury. Yes, there is a catastrophic brain injury. That point is, have they mentioned GCS anywhere saying that it is 4 or less than 4? They have not mentioned anywhere saying that GCS is 4 or less than 4. And they have not mentioned anywhere this patient is brain death. So the new guidelines, what they say is whenever there is a catastrophic brain injury, if the neurosurgeons refuses, what they say is admit the patient in ICU. Okay, it is best you admit the patient in ICU. Why you are admitting this patient in ICU? You are admitting this patient in ICU because there is a minute chances that they can recover over the time. The guideline says that you re-examine the patient after 24 hours and after 72 hours also if there is no recovery, then you can think of brain dead and check for the brain dead reflexes and plan for the organ donations at that point of time. Here, you need to shift this patient to the ICU because you're thinking this patient might have minute chances of recovery. Let us shift this patient. It's already been intubated. Let's just shift this patient to the ICU and let us re-examine after 24 and 72 hours and take a call at that point of time. Remember, brain death is not mentioned here specifically. One more question will come where the brain death would have specifically mentioned. If he's already brain dead, then you can talk for the organ donations and involve the SNOT, specialist nurse for organ donation. A 75 years old female was brought to the MS department by her husband. She develops a sudden weakness in her left side of her body 2 hours back, which resulted in a fall. Her vital parameters are within normal limits. The patient was immediately shifted for NCT brain, which shows an hyperdense MCA sign. What is the next best step for you to take before thrombolysis? What are you doing before thrombolysis? So 2 hours back, there is a stroke. You have why we get a CT scan done? We get a CT scan done to rule out if there is an hemorrhage. There is no hemorrhage there. Hypertension is usually suggestive of an infarct. If it is not suggestive of an infarct, also you can go ahead because it is within 4 hours time. You can go ahead with the thrombolysis. For thrombolysis, what do you need? You need an consent. This patient has a stroke. Stroke. Whenever there is a stroke in that is a suspicion that patient might not have the capacity. So you need to check for the capacity here. You need to check for the capacity and see whether the patient has the capacity or doesn't have the capacity. If the patient doesn't have the capacity, then you'll be checking for the LP or AD. If LP and AD are not present, you're treating the patient in the patient's best interest at that point of time. Here, the first step is to check for the capacity. A 16 years old female present to the ED with complaints of pain abdomen. She gives a history of multiple sexual partners. LMPS 4 weeks back. On examination, patient's vitals are within normal limits. UPT is negative. You make a diagnosis of PID. What is the next best step in the management? What you will do? What are we suspecting here? We're suspecting a sexually transmitted disease. Guideline says when you are suspecting a sexually transmitted disease, best thing is refer to the genitourinary medicine, that is a gum clinic. Okay, you can refer to the gum clinic. The problem here is she's only 16 years age group. Is she understanding what you're telling? That you need to see. That is nothing but glic competent. If they're glic competent, you will be just referring to the gum clinic follow-up and you will be discharging the patient. So fifth one will be most appropriate. Same thing, I'll change the age here. For example, I keep the age as 12 years. What will be the most appropriate answer here? Anyone, what will be the most appropriate if I change the age to 12 years? No, option 3, social services, is wrong. Option 4, yes, option 4 is the right one. Because anyone who is having a sexual intercourse, multiple sexual partners at the age of, so anyone less than 13 years has a sexual intercourse, it is considered as a rape and you need to involve the police immediately. So the right option will be, if the age changes to 12 years, will be inform police. 70 years old cancer patient who has mental capacity was brought to the ED by his daughter with abdominal pain. His daughter is LPA. The patient is requesting only pain management and doesn't want any investigations. But the daughter is requesting you to investigate and treat the patient. What will be the most appropriate action here? What does the patient want? Patient wants and just the pain management the patient is wanting. There is an LPA. Is this LPA valid? No, there is nothing here suggestive of the patient doesn't have the capacity. So we'll assume that we always assume that the patient has the capacity. So LPA will become invalid here if the patient has the capacity. So as the patient has the capacity, you need to listen to the patient's wishes and respect the patient's wishes. Yeah. So the patient's wishes are manage the pain and discharge him. That's what he wants. So you'll be doing accordingly. You are the senior doctor on the night shift. Police arrives to the emergency department and request you for an last night patient list. They are keen on knowing the number of injured patients who are involved in the accident. What will be your most appropriate action? You can give this because again, road traffic accident, personal information can be given. So according to the Road Traffic Act, you are giving the personal information here. So collect the information and give it to them. Give complete information details from the record. We cannot give complete information because it will include their medical records. For that reason, the option number 5 is the wrong one. Option number 4 is the right one. Take his number, tell him to call back, or tell him to contact the communications, or tell him to contact the secretary on the Monday, or inappropriate things. You're just making the police to roam around and referring him. You are washing off the responsibilities on others, or you're just making them to roam around. This is your responsibility to give the information if they come and request. You come across and post on the social media which your colleague has posted. It is about a case seen in the hospital, which has the potential to expose the identity of the patient. What is the most appropriate action? What you will do, you'll call up your friend and tell him, remove the post because I think your patient's identity will be revealed. Confidentiality is at risk here. Why? So I think you might have not thought about it. Please remove it so you'll be at safe. So you are helping your colleague here. So discuss with your colleague, ask him to remove the post in a nice manner. Okay, and help out your colleague. Inform the consultant whom the patient is under or complain to the legal. It is all an overkill what you're doing by doing all these things. If you can just remove the post, you can prevent the identity to be revealed here and the confidentiality will not be broken for that reason. You're teaching a group of students, you're rotating in the emergency department. The topic of teaching is advanced decision or advanced directive. Regarding the advanced decision validity, which one of the following statement is wrong? They're asking. The advanced decision must have been valid by the patient when they are an adult, has had capacity and were properly informed. Absolutely right one. The statement did not specify specifically what treatment is to be. No, it has to be specifically. It is the wrong statement. It has to specify what treatment is to be refused and the circumstances in which the refusal should be applied. It has to be particularly specified in the document. Advanced decision will not apply once the patient lacks the uh, capacity to consent to or refuses the treatment. Yes, it only applies when the patient loses their capacity. Advanced decision that relates to the refusal of the life-saving treatment must be written and signed and witnessed. And again, absolutely right. Advanced decision may be invalid if withdrawn with the person had the capacity. Again, it is the right statement. So the false statement is the second one. A patient's identity finds an handover list in the parking lot and gives it to the receptionist who informs you of this. You are worried about the compromise of the patient's personal. What will you do? This is a difficult one. Basically, they want you to inform to the information governance office. They will evaluate and take a call what next to be done. So just remember this. If at all, if this question repeats again, you need to pick up the option number one or any option where it informs that information governance officer needs to be informed. You just remember that point. Going in detail of this law itself is not important. It's just waste of time, what I feel. So just remember this point. If they test you, they'll ask you similar question itself in the next diet, in your diet. You are called to the observation ward, that is CDU, clinical decision unit, where an 16 years old male is causing a disturbance. He is heavily intoxicated and has taken an overdose of a large amount of paracetamol requiring treatment with N-acetylcysteine. However, he does not want to complete the treatment and instead want to leave the hospital. What will be the most appropriate action here? What has happened? First thing is he wants to leave the hospital. So you need to take a consent. To take a consent, we need to see whether the patient has the capacity. I say he doesn't have the capacity. Why I'm saying he doesn't have the capacity? He's heavily intoxicated. Intoxicated persons, you can assume that they do not have the capacity. As they do not have the capacity, what you will do here at this point of time, you need to treat it in patient's best interest. So under the common law, you will call the security, restrain him, if required, sedate him, and treat him for the paracetamol overdose. This question has appeared in last date, that is September 24. An angry mom comes to the emergency department asking who treated her daughter. A couple of days back, you treat her for 15 years old daughter for PID. Mom wants to know the diagnosis and the medical details of her daughter. Which one of the following is true regarding the disclosure of the patient's medical details? Here, daughter is 15 years. So anyone who is 13 or more than or equal to 13 years age group, we consider them as an young adults. Young adults, we usually consider them to be competent enough, especially if they have the Gillick competency. And according to the phrases criteria, they have rights for the confidentiality, especially regarding the sexual activities. So the right one is the daughter has the right to confidentiality. It is already tested in OSCE in last date, previous to that also it was tested. So remember this, they have the right for confidentiality. You shouldn't be giving the information to the mother. Call daughter for the consent to give the information. It is inappropriate. You're putting the daughter on spot at that point of time. So you shouldn't be doing that. Give the information, absolutely not. You will be breaking the confidentiality. Seek senior help. You are already a senior. So most of the time, what you need to take the decisions rather than involving a senior. Refer to the doctor who has seen the daughter. No, again, you are basically blaming another doctor or giving the responsibility to another doctor. Young female, a frequent visitor to the ED, came with complaints of abdominal pain. She has presented to the ED 18 times in the last 6 months with similar presentation. Her vital parameters are within normal limits. The examination is completely normal and lab reports are within normal limits. You diagnose her as an MUS, we call it, as a medical undiagnosed syndrome. The patient is asking what is wrong with her and what will you tell her? Tell her the truth. Tell her that she has MUS and no specific treatment is required for this. Okay, you need to be frank and you need to tell what exactly is happening. You shouldn't be telling anything lie unnecessarily. You shouldn't be admitting because you already done a complete examination and you got the routine investigations done. There is nothing to suggest you up. So you shouldn't be doing anything else here. So tell her what exactly she has and tell her no treatment will be required. A 15 years old arrives to the ED with what looks like a stab wound to the leg. No other injuries are noted. He's invasive about the cause and asks you to just deal with the wound without asking more questions. You close the wound by suturing and dress the wound. Which of the following is the most appropriate action? Whenever there is a stab wound, and here he is not telling how it has happened. That should raise a suspicion that someone else might have stabbed it. So any stab wound with a sharp object or any gunshot wound should immediately inform to the police. So the right answer here is police. So we have three things we have learned about to inform to the police. So any gunshot injuries, any stab injuries of an sharp object, or any injuries because of a sharp object. Next one is female genital mutilation. These are the three places where we directly involve the police as the first step. A 76 years old man has arrived by ambulance to the emergency department after a fall at a daycare center. His ankle is clearly causing him significant pain. However, he doesn't want anyone to look at it. He wants to go back home immediately. Which one of the following is most appropriate as a first step? Again, severe pain can make the patient delirious. So check for the capacity. Okay, if the patient has a capacity, you cannot restrain, you cannot do anything. If he doesn't have the capacity, you'll be seeing LPR, AD is present. If that is also not present, then you'll be treating the patient in patient's best interest. Elderly male, unknown case of COPD and chronic smoker present to the ED with the complaints of shortness of breath and cough with expectoration. He was discharged 24 hours ago and was treated for similar complaints. His previous records show multiple ER visits and admission for similar complaints. On examination, his vitals are stable. He doesn't require medical admission. He wants to be admitted as he is afraid of deterioration and lives alone. Which of the following is the most appropriate action? He is an elderly fellow. Okay, he lives alone. He's afraid his deterioration. So you can do an social admission here. A social reason for admission is required for this patient because if he deteriorates at home, there will be no one to take care of him and he cannot come back to the emergency department because he lives alone. It can be disastrous. He might even die. For that reason, admit him overnight and refer to the respiratory nurse because he has recurrent admissions for the similar complaints. They might arrange something. They might make sure that COPD doesn't get worsen. An elderly couple arrives to the ED department. The husband is 75 years old, complaining of the right upper limb weakness since a week. The wife is 73 years old and complains of facial weakness, right upper limb and lower limb weakness since 3 to 4 hours. Which of the following is the most appropriate action? So, what are you suspecting in both husband and wife here? In both, you are suspecting there is a stroke. In stroke, what do? We get an CT scan done. So, both of them needs to get an CT scan done. Advice CT scan for both of them needs to be done. Here, one wife, it is very important to get a CT scan done on an immediate basis. If they ask you to select one, then wife needs to get a CT scan done first, followed by husband, because wife has the complaint since only 3 to 4 hours. Ideally, CT angiography will be done for this to see whether you can do and thrombolysis or thrombectomy can be done to take that option. So right answer here is advice CT scan for both of them. Same couple, the previous day, an elderly couple came to the ED department. The husband had everything holds good till here. It's the same scenario. As the ER was busy, they left. And today they have come back with the wife was brought dead to the hospital. Which of the following is the most appropriate action? Why the wife is dead? Do we know the reason here? We do not know the reason. We do not know the reason here. For that reason, what we'll do whenever there is an death and you do not know the reason, we always refer to the corona. So we need to look at the option which says involve the corona for death certificate or basically refer to the corona here. Corona will investigate and take a call what next to be done. This has appeared in September 24 also. A 44 years old male unknown case of diabetic presence with an abdominal pain with multiple episodes of vomiting. A diagnosis of DKA was made. The patient is in shock, hence your consultant advised you to insert a central line in the femoral vein. The ED is going to receive 2 other cases, so the consultant going to attend the other cases. You have not performed a central line before, but have read about it. Which one of the following is the most appropriate action here? Remember that there is a learning curve, what we tell. Learning curve is first theory you will be learning, how to perform, you'll read up in the book, see few videos and all. Then what you'll be doing, you will observe. For example, a consultant is performing the procedure, so you'll observe how he's doing the procedure. Once you are observed, you will assist. Okay, you will help them doing assisted, for example, placing the guide wire and all. Then what you'll be doing, you will be performing the procedure. You will be performing the procedure under observation. When you perform the procedure under observation, if the consultant is happy with your procedure, then he'll sign you off. Sign you off means he will sign that you're competent enough to do this procedure on your own. That's when you will perform the procedure. Only you will be performing alone. So this is known as learning curve, which is completely or is always followed in the NHS everywhere. So what you'll be doing here? Ask a fellow colleague who knows to do an femoral line and you assist in another recitation. Okay, seems quite fair enough. We'll keep this option. Take your study materials and revise and perform the procedure. It will be dangerous to the patients. You may not be able to perform it. Keep trying IV access with an USG. No, the consultant wants you to a central line. Ask a colleague to observe you while you do it. Might be an appropriate one. Tell your consultant that you cannot do it because you have never done it. It's a more important or more appropriate one if you compare to the option 1 and option 4. Why? Because consultant is the one who allocates which cases needs to be seen. Okay, if you tell the consultant that you're not done it and you're not confident to do it, he might allocate someone else and he might decide who else has to see. You changing and flipping the cases with another colleague, or you are taking one more colleague who might be utilized to do something and under his observation you're doing it, may not be appropriate. So it is always important to inform the consultant who is head of the department or who is running the department at that point of time to be aware what is going on. So informing the consultant that you cannot do it because you have never done it is the most appropriate answer, because you are being frank and you're telling to the consultant, to the right person you're informing, and you're telling the right thing to the right person here. A mother of a 14 years old female comes to the ED requesting to see the doctor. Mom is requesting contraceptive pills advice for her doctor. On further questioning, she says her doctor is in the school, hence didn't come with her. What advice will you give to the mom? Advise mother to call daughter for contraceptive advice. Daughter might not want contraceptive advice at all. That will become an inappropriate thing to do. Give OC people's prescription? Absolutely not. Daughter should come. Advise the mother that the daughter has the competence to seek the contraceptive advice. Why are you coming? She's 14 years. Let her come and seek, then we'll give it. That should be the right answer. Send mother and daughter for the GP for further discussion. No, we do not know. You're not spoken to the doctor at all. You don't know what is happening. You cannot use the treatment when someone else comes and asks in behalf of them. Use barrel method contraception. Again, wrong, wrong. A 37 years old was brought to the emergency department with an head injury after a road traffic accident. The CT scan shows a large intracranial bleed. The neurosurgeons have reviewed the case and refused surgery as the patient is brain dead. You break this pattern to the family. They do not want to believe the diagnosis. What will be your most appropriate action here? Its patient is already brain dead, so he is an potential donor. Whenever there is a potential donor is present, the first step is to involve the SNOT. SNOT stands for Specialist Nurse for Organ Donation. So you're calling the SNOT. With the SNOT nurse, the whole team will go and discuss about it. A 2 years old child was brought to the MS department by her parents. They complain her behavior was a change and she has been not playing as usual since the last 2 days. They give an history of her being babysat by her uncle a couple of days back. You suspect in sexual abuse. Bruise over which site is indicative of sexual abuse? It's an inner thigh. Similar question we have already discussed. A 15 years old girl present to the emergency department with a self-harm to the left arm. She is feeling much better now. She has no suicidal ideation. She is happy to go back home to the family. On examination, superficial incised wounds are noted over her clean that have been cleaned and closed. You have noticed multiple scars over the rest. What will be the next step? There is certain amount of depression, certain amount of psychiatric issues going on. Ideally, we want them to an outpatient camps. That stands for psychiatric review in the outpatient. That option is not given. So outpatient GP also will be more appropriate. That's why the option 3 we are choosing here. Urgent referral to a camp might not be required here. Urgent referral means seen in the emergency department itself. No, it is not required to be seen. It can be seen in the outpatient department because there is no suicidal ideation. 20 years old female is brought to the ED from a prison. There is a history of assault and she has sustained injury to the head. On assessment in the ED, the patient is brain dead. Again, they have mentioned brain dead. She has a significant past medical history of HIV. She has been living in UK for the last 8 months. There is no next of kin. She may not be eligible for organ donation as she is. As she is living only for 8 months. She needs to live for minimum 12 months. Otherwise, it will be in the exclusion group. HIV infection for another HIV infected person, they can transfuse. Next of kin, no. Prisoner, no. Again, no. A senior consultant asks you to audit lower back pain patients presented to the emergency department. You oblige and start collecting the data. While collecting the data, you notice that there is a medical record that includes information regarding the patient's religion. There is a breach of which of the following act here? There is breach of Data Protection Act. Data Protection Act clearly says that sensitive information like race, political opinion, religious belief, genetics, or sexual orientation, biometrics, all those are very sensitive information, shouldn't be used for any reasons. So Data Protection Act will protect them. So it is a breach of Data Protection Act. They're asking which one of the following is a contraindication for organ donation. Smoker, no. Alcohol, no. HIV persons can donate to another HIV persons. Myeloma. Myeloma is an hematological cancer here, but it is in remission. They also can donate. Renal cancer 2 years ago with an T2N1. So this is an active cancer. Because it has spread outside the organ here, even though they have operated, it has spread to the nodes here. N1 stands for nodes here. So this is considered as an active cancer, and this is the right answer here. A 45 years old was brought to the emergency department with an alleged history of assault and sustained injury to the head. His 15 years old son, who smells of alcohol, was brought to the emergency department along with him. This is the important statement. City head shows intracranial bleed requiring hospital admission for the father. Which one of the following is true regarding the son? Social services for safeguarding, admit the 14 years old, contact to child well-being, seek legal help, do a skeletal survey. Do a skeletal survey, we do not do it. Legal help immediately will not be available in the emergency department. If it is available also, it is time consuming, you cannot take an immediate decision. Contact to child well-being, social services, or admit. It's better to admit. We do not know what exactly has happened. Has the kid got assaulted, or the kid has drank and he has assaulted the father? What has exactly happened? We don't know what the situation. But if you remember in our previous chapters where we studied about the alcohol, I think in the psychiatric chapter, I told you any underage persons comes with an alcohol intoxication, admit those patients. So according to that information, we will be admitting this patient. He's an underage. Anyone less than 18 is considered as an underage. Usually, they shouldn't be drinking. Okay, he's not an adult. He's a teenager. How did he can get access to the alcohol? Is he forced to be drunk, or he has stolen it from somewhere? So all those questions will arise. So he needs to be admitted and later on evaluate and see what the hell has gone wrong. An infant was brought to the emergency department by a worried mom seeking immediate medical attention. She complains of baby not breathing. The baby was immediately received in the resuscitation room. CPR was started as the baby was in cardiac arrest. On assessment, the baby was in rigor mortis. That means the baby has been dead a long time back. You continuing resuscitation is no point. The mother wants you to continue resuscitating the baby. What will be the next step? You just withdraw the CPR, explain and counsel the mother. Mother always wants you to try and try and try. But here, rigor mortis has developed. Continuing CPR is waste of time and waste of energy and waste of resources. For that particular reason, you need to stop the CPR and explain the mother what has gone wrong. You cannot use ECMO in this situation. Absolutely wrong. Continuing CPR is again wrong. Call consultant pediatrician for what? You already know that this kid is been dead since long time. Continuing resuscitation till consultant arrives also is a wrong option. So what is the diagnosis here? Anyone, what is the diagnosis here? Anyone? Okay, it's a SUDIC, or the patient is having. Sudden unexpected death, what you are having, it is a SUDIC. A middle-aged female present to the emergency department. She gives a history of cocaine addiction. She is seeking help for the addiction. The husband has the parental responsibilities at home with the children. Which of the following is most appropriate? They are anyone who is an addict are at the higher risk for child abuse. These children's needs and child safeguarding, but immediate protection of them is important. Who is with the child? Husband. Husband has the parental responsibility. So all the husband inform about the mother's addiction to protect the child will be the most appropriate answer here. One of you is asking here, 51st question, if he is 18 years old, what you will be doing at that point of time? 18 years old, he's still alcoholic and brought to the son. What has happened? We do not know. Still, we'll be admitting the kid, 18 years old. You are taking care of a patient who was involved in an assault and sustained multiple stab injuries. His airway is compromised. Hence, you intubated him and connected him to the mechanical ventilator. Police arrived to the ED and requesting information as the incident is ongoing and there is a risk for general population. What is the most appropriate action here? What information can you reveal or what can you give to the patients? Personal information can be revealed here because general population is at risk. He might stab to other people also. Name, address, injury details also you can give because the weapon what is being used, it will help them to identify by the police. So the right answer here will be the second one. Elderly female unknown case of liver body dementia was brought to the MS department by her husband with complaints of choking. She has seen in the triage as the ED was busy with a long wait time. The patient left ED without informing. The next day, the patient was brought dead. What brought dead? So we do not know the cause. So what will be the next action? Inform the coroner. So you will be referring to the coroner here. Again, similar question what we had discussed previously. Elderly female with and past medical history of a TIA present to the emergency department with an right upper and lower limb weaknesses, which was noticed 2 hours back. The CT scan showed an MCA infarct. NHS score is 12. You decide to thrombolize as it is the best treatment option for the patient. The patient seemed to have capacity, but she refuses thrombolysis, wants to go home. What is the most appropriate action here? Does she definitely have seems to have capacity is not a right thing because you get into the legal scope here. You need to always check for is there an understanding is present, is the patient able to retain, is the able to weigh the pros and cons, and is the patient able to communicate. So four things needs to be checked for to say the patient has the capacity. Why we are not assuming the patient may not have patient, always we assume the patient has the capacity. We are thinking the patient may not have a capacity here because of the stroke what the patient is having. There is an infarct, suggestive of a stroke. For that reason, check for the capacity. They're directly not given check for the capacity here. Ask senior colleague to assess the capacity will become the most appropriate or likely answer here. Take consent from the husband. No, if the patient has the capacity, the patient himself should give the consent. Ask the husband to convince the patient. We do not know whether the capacity is there or not. So you cannot ask. And again, the consent should be given voluntarily. There shouldn't be undue force from anyone. So again, it becomes a wrong one. Go ahead with thrombolysis. You will go ahead with thrombolysis in patient best interest if the patient doesn't have the capacity and doesn't have an LPR AD. Allow her to go home as she has the capacity. We do not know. Seem to have is not a right option. You need to check it. If the patient has the capacity, you need to check it first. A GP referred an alcoholic patient to the emergency department. Email the ED doctor details regarding the patient. Patient vital parameters are within normal limits in the emergency department. On discussion, is requesting to see the email sent by the GP to you. What is the next best step? GMC says that information patient will be able to see on the records is any free test, any free test, any letters, documents, coded information, he has the right to see it. Will not be able to see or he doesn't have the right to see it is administrative task and communication between the practice staff. Here what has happened, it is a communication between two doctors. One is the GP, another one is the emergency physicians. It is a confidential information what is the communication is. For that reason, you need to refuse saying it is a confidential information. It's a confidential information shared between the two doctors. Okay, that what is the discussion, what communication happened between you two, he cannot see it. But he wants to see his own records, what he is having. He wants to see his reports. Those things he has the rights to see it. But he doesn't have the rights to see the communication between the two doctors or two nurses or two practicing staff. A 49 years old male was diagnosed with, male was diagnosed by his GP with an infected leg ulcer. Wound stab, wound swab shows sensitivity to clindamycin and vancomycin. The GP has prescribed clindamycin. The pharmacist has called you for advice as the GP was unavailable. He informs you that the patient had pseudomembranous colitis 1 week ago. What advice will you give to the pharmacist? So what has happened? Pseudomembranous colitis the patient is having, and they have prescribed him the clindamycin. Clindamycin can again trigger this infection, so he shouldn't be on this. So instead of this, you should be prescribed an vancomycin because you know the sensitivity is there for both clindamycin and vancomycin. This prescription needs to be changed. So you are being nice to your colleague. Here the colleague is a GP. So prescribe the vancomycin, then ask him to follow up with the GP so that the GP is also aware that you have changed the prescription for this particular reason. So the option 3 becomes the most appropriate one. Asking the patient going back to the GP unnecessarily, you're making the patient to go to the GP again, come back. So you're not being nice here. Ask the patient to come to the ER and you will refer him to the medical team. Again, you can do it. You have all the information to change the prescription here. Call him back and discuss with the microbiologist. Not required because you already have the information here. Tell him to try contacting a GP again. Again, you're making the patient to walk more. Elderly female present to the emergency department with complaints of on and off giddiness since the last 2 days. Since the last hour, she has been complaining of complete weakness of the right upper limb and a lower limb, along with the receptive aphasia. Her vital parameters are within normal. CT image has been given. What is the most appropriate next step? First thing here is they're asking for the treatment. We need to take a consent. For the consent, we need a capacity. Does the patient have the capacity? I say no, the patient doesn't have the capacity. Why am I saying the patient doesn't have the capacity? Because the patient has a receptive aphasia. That means whatever and all you explain, he'll not be able to understand. If he's not able to understand, this is the first step. Understanding is the first step in checking for the capacity. If he's not able to understand, we can assume that the patient doesn't have the capacity. So what will be the next thing? Doing a checking for LPR-AD, which is not mentioned here. So you'll be treating the patient in the best interest. Best interest is to thrombolize the patient in the patient's best interest. So option 2 will become the right option. An elderly female was brought to the MS department. She is a known case of end-stage cancer and presents with a cough and shortness of breath. A diagnosis of pneumonia is made. Son has AD, which suggests the palliative management. The daughter has an LPA, which is the latest one, and she is requesting you to treat the patient aggressively. The patient is refusing any treatment. What is the best next step here? So there is one LPA, there is one AD, and does the patient have the capacity? Yes, the patient has the capacity here. If the patient has the capacity here, LPA and AD becomes invalid. So you're not breaking your head at all. So what and all the patient wishes is there, you will be treating according to it. So treat according to the patient wishes will become the right answer. And it makes sense also here. Why it makes sense? The patient is quite elderly and has an end-stage cancer. So treating aggressively to an end-stage cancer doesn't make, so patient wishes also makes sense here. A 5 months old baby was brought to the MS department by his mum and mum's boyfriend with complaints of continuous cry. Mum says that the baby rolled off the bed and injured the right arm. X-ray shows a humerus fracture. The orthopedic team has received the case, reviewed the case and placed an above elbow back slap. Which one of the following will be the next best step here? We are again strongly suspecting a non-accidental injury in this patient. Because of a severe injury, what is there? Rolling of 5 months might not be present. Okay, but the injury is quite significant to make you think of non-accidental injury as insignificant or highly suspicious of non-accidental injury. When you're highly suspecting a non-accidental injury, first thing is to involve the social services. That's what you're doing. Same thing, I'll change it up. Instead of a humerus fracture, there is a small bruise over the right arm is present. What you'll be doing? X-ray has been taken, fracture has been ruled out, a small bruising is present. What you'll be doing at that point of time? No, it is not involve the social services. It's a small bruise which is present. 5 months old can have an rollover. The injury what is sustained is not a significant injury what is sustained. So what we can do is we can fill the multi-agency referral form here and refer them. Yes, one of you got it right. Yes, fill the multi-agency referral form. What you'll be doing. If you're not strongly suspecting a non-accidental injury, multi-agency referral form. If you're suspecting strongly non-accidental injury, social services. If the mom leaves the emergency department with the kid, at that point of time, you'll be involving the police. A 2 years old kid was brought to the emergency department with burns to the hand. On examination, you notice first degree burn over the hand. Mom says burns are due to holding a hot cup. You suspect a non-accidental injury. Which one of the following is suggestive of a non-accidental injury here? Burn over the palm. Usually you grasp the glass with your palm itself. Palmar surface will be touching the glass. Good eye contact, no. Crying might be multiple reasons. Severe pain also multiple reasons. Burn over the dorsum of the hand. How you will hold the cup or the mug? You will be holding with your palmar surface, not the dorsal surface, not behind the surface of your palm. there should, if the burns is there, you need to suspect that can be a non-accidental injury because it's an unusual place to have a burn. The history doesn't fit in what mom is giving. A 19 years old boy presented to the ED with an injection of 10 tablets of ibuprofen. He says he took it to end his life. The triage nurse has documented the vitals. After some time, the patient has absconded. You have noticed the police you have called the police to inform them that the patient has absconded. What is the likely reason to involve the police? To involve the police, what we do? We have the five reasons should be present. Consumption of 10 tablets of ibuprofen? No. Why you'll involve for this? Mental capacity is not checked, you'll not involve the police. Risk of committing suicide? Yes. If there is a risk of committing suicide, there's a risk of life. Immediate risk of life is present. You involve the police? Yes, that's the right one. As he is 18 years old, no. Lives alone, no. You shouldn't be calling police for this reason. But if there is a risk of committing suicide, yes, you will be involving the police. A 27 years old present to the ED with bleeding in the mouth. He had undergone tonsillectomy 7 days back. On examination, his vital parameters are hypertensive is very important along with tachycardia. So significant amount of blood loss is there. Ongoing bleeding is noted from the operation side. The anesthetic registrar has reviewed the patient in the emergency department and denied going along with the patient as the airway is patent. What is the most appropriate next step in the management of the plan? First thing is the bleeding is there in the mouth. There is an active bleeding is happening. Whenever there is an active bleeding is happening inside the oral cavity, we are worried about aspiration. If you are worried about aspiration, we always intubate the patient. Or we are worried about the airway here. Airway can be compromised because we are worried about we are really worried about the aspiration because of the continuous bleed. Now the reason next problem is we are worried about the airway here. The next problem is you do not have an ENT here. You are called to the next hospital. They are telling to shift to the next hospital. Can you ask him to come to the your emergency department and treat it? It is not a good idea. It is a good idea to shift the patient there because he coming to your hospital, he may not be knowing how the hospital works, where are the equipments. He may not be the entire team will not be coming here. He might require a surgery where entire ENT team might be required for him to operate. For that reason, it is always good idea to shift to the ENT center itself because bleeding has to be stopped. While shifting, you cannot shift him alone. Why you cannot shift him alone? Because you are worried about the airway, he can aspirate at any point of time. So you need an anesthetic. Anesthetic here, registrar is refusing. If anesthetic registrar refuses, you need to escalate it. To whom you will escalate? To a consultant level. So call the consultant and inform him about the situation, what is happening here, so that consultant says him go. That's how you're escalating the situation here. Ask the senior nurse to accompany. Senior nurse cannot intubate, so no point. Delay transfer and transfuse the blood. If the tap is open, no matter how much blood you give, he will die eventually because there is active bleeding. You need to try to stop it. Blood transfusion is a good idea, but can be transferred ongoing in the ambulance also. Ask the ENT registrar to come to the ED. Again, not a good idea because entire team is required. Transfer with paramedics. Again, nurse, paramedics. No, we want an anesthetic doctor here. If you do for stabilization, how you will stabilize if there is an ongoing bleed? He'll not stabilize. You need to stop it. There's already bleeding is going on. No matter how much blood you give, he will be bleeding. Eventually, he'll die if you keep more time in the emergency department. A senior consultant emails you requesting to do an audit on the number of transfusions that happens in the emergency department, also to collect the religious details. According to the Data Protection Act, it breaches which code of conduct? Religious details is protected by the Data Protection Act. It says that used in a way that is adequate, relevant, and limited to only what is necessary. This is what the Data Protection Act really states of. Used for specified explicit purpose, partially right, not completely right. Adequate, relevant, and limited to the only what is necessary is the more correct option here. Kept for no longer than necessary, partially right. And handled in a way that ensures appropriate security, including protection against unlawful, unauthorized access and loss of destruction of the damage. This is called person's responsibility. This doesn't come in the Data Protection Act. Used for unspecified purpose, again, this is completely wrong statement. The fifth one is also a completely wrong statement. A 42 years old female unknown case of bipolar was brought to the MS department with an alleged history of consumption of propranolol. The trial nurse has seen her and triaged her. Her vital parameters are within normal limits. The nurse asked her to wait to see the doctor. After 20 minutes, the patient is missing from the cubicle. You called the patient's mobile number, but there was no response. What is the most appropriate next action? Police, we do not call police immediately. Okay. Call to the next of the kin. Yes, we can do it. Do not bother contacting the patient. Absolutely wrong, because beta blocker overdose can lead to death also. Document and inform your consultant the next day. No, you cannot ignore it. Checking the security and checking the ED surroundings should be the most appropriate next step. If after checking the ED and securities you are not able to find it, next appropriate step will be to call next of kin. Calling next of kin also you're not able to find it, then it becomes appropriate to involve the police, because there is a life-threatening thing which has happened, beta blocker overdose. Because of beta blocker overdose, the patients can die. There's an immediate risk for life. Then it becomes sense to involve the police. So remember, you're involving checking the ED itself. What happens? You call, for example, you call some relative, sister of this person you call. Sister will be panicked. Then you find out the patient was in the ED itself. He had gone to some other cubicle. Then it will be quite insulting to you, and sister will be very furious. You made me panic. I worried and came here, and the patient was here itself in your emergency department. So it is always first check your ED, check your surroundings in the ED. You call your security guards and check CCTV. That should be the first thing. 85 years old was brought to the MS department with an altered sensorium. On examination, the left pupil is dilated and the right pupil is constricted. The patient was intubated and transferred for a CT scan. The CT scan showed massive intracranial bleed with midline shift. Neurosurgeons informed me that patient is not for surgical intervention. The patient relatives wants to know about organ donation. Which are the following correct about the organ donation in this patient? Can donate organs only. Organs and tissue donation is not an option. Can donate organs and tissues. Can donate heart walls and skin. Can donate tissues only. He can donate both. Organs and tissues can be donated. Age limit is not there. The final decision will be taken by organ donation team, whether they are viable or not. So can donate both organs as well as tissues. A nurse informs you that the patient's husband, who is a medical consultant in the NHS, has taken a copy of echo result and sent it to a friend who is a cardiologist for review. The wife is unhappy with the husband's behavior. Which one of the following statement is appropriate? We'll go from the below to the top one. The husband has the right as he works in the NHS. No, he doesn't get any rights to break the confidentiality. Wife, even though he's a husband, he needs to take permission from the wife to access this. Cardiologist can assess the reports if she is a parent. Yes, he can assess the reports, but not directly. He needs to come and ask you and request you. He cannot come in your department and just open the computers and start assessing. He needs to request to you and say that I am the cardiologist of the treating of this patient. I want to see it. On request, you can give it. The husband shares. Husband can share because the cardiologists and medical consultants are friends. No, you're breaching the confidentiality here. If the wife gives consent, the husband can access the information. Yes, if the wife gives, husband can access, but he needs to come and ask you the permission. He cannot directly access. If the wife gives consent, husband can come and ask you for the information. Then you need to find out whether wife has given the consent or not. If the wife has given the consent, at that point of time, you can reveal the information to the husband. The wife has the right for confidentiality is the absolutely right statement here. A nurse informs you that a police officer wishes to speak with you. The police request information about a patient's age between 16 to 30 years. Under what circumstances can you disclose this information to the police officer? What at what circumstance you can information can be disclosed to the police? Suicide attempt? No. It was an homicide? Yes. Illegal immigrants? No. Nowhere we read about it. Missing person? No. Suspecting tuberculosis, you can break the confidentiality, but the information is not shared with the police. The information is shared with the local health protection team or local authorities. It is shared with for the health protection team. It is not with the police. Police has nothing to do with the suspected tuberculosis. A person with a gunshot wound? Yes, absolutely right. The third option will be the right one. An elderly schizophrenic female is referred to the ED department by her physiotherapist. During her physiotherapy session, the physiotherapy observes multiple bruises at different stages of healing. The patient husband, who holds the power of attorney, lasting power of attorney, is insisting on discharge her and taking her home. What is the most appropriate next step here? Ask to follow up with the GP. No, you're worried about what? You're worried about safeguarding here. Elderly safeguarding you're worried about. So ask them to follow up with the GP will be highly inappropriate. Call to the police. Call to the police if they would have left the emergency department. Immediate risk for the life is present. Call next to the kin. Next to the kin is already here. So no point calling here. Discharge and send social services at home. There are two options. You can discharge and send social services at home. Discuss with husband you want to admit for safety. So which one is important here? Either you discharge and send social services at home, or discuss with husband and you want to admit for her safety. The most appropriate here, what I recommend is to go with the option number 2 instead of going with the option number 5. The reason is, though we are suspecting a non-accidental injury here, we are not sure here why the non-accidental injury is. What is the reason here? So it is appropriate as in place of safety to admit it and further evaluate and see, is there anything, especially in elderly people who have schizophrenia, dementia, it's better you admit and see, are there any other issues going on? Is there any coagulopathy which is causing a lot of bruises to this person? In elderly person, it's better. So it is a safer bet to admit the patient than discharge and send social services at home. That's why I'm recommending to choose the option number 2 rather than option number 5. A 70 years old Somalian girl, whenever this comes, we always worried about, whenever this is mentioned, we are always worried about female genital mutilation, was brought to the ED by her grandparents with bleeding from the vagina. She denies any fever, her vital parameters are within normal limits. On examination, the nurse notices blood in the underway and she has a poor eye contact. There are no previous visits to the hospital. She is clinically managed. And what is the most appropriate next step here? That is, inform the police, because this is a female genital mutilation. You need to immediately inform to the police. It is highly illegal in UK. The radiologist has called you regarding a chest X-ray, which was taken yesterday. He reports that chest X-ray is suggestive of a pneumothorax measuring 1 centimeter. You check the records of the patient. The case was seen by an FI2 doctors who were discharged as a diagnosis of musculoskeletal pain. The patient was stable and no comorbidities. What is the most appropriate next step? Always remember, you need to think that patient safety comes first. Patient safety is paramount. Patient safety comes first. That's why we need to always think of patient safety first. So thinking of a patient safety, inform the consultant about the event. Yes, we need to do it. Call the patient to the ED to review. That is the most appropriate thing to do it. Do datics. Yes, incident reporting has to be done because this has been missed. But again, we might have to talk to the FIO doctor and see his competency level also. Call FIO doctor to contact the patient. This becomes an overkill. You're just torturing the FIO to here. Send the letter to tell the patient he needs to follow up with an X-ray. No, he needs to come to the emergency department, see whether he's doing all right, because pneumothorax can expand, and you need to tell him to he needs to follow up with an just physician there. So how he is progressing, immediately you need to review this patient. So call the patient to ED to review will become the most appropriate answer here. One of you are asking why not? Why not? As I told already, I've explained. You can go back through the recorded video. An elderly patient was diagnosed with a pneumonia. Based on the high CRUP 65 score, you decide to admit and administer IV antibiotics. However, the patient is on palliative care and has full mental capacity. He clearly expresses a desire to discontinue further treatment, including antibiotics. The patient's daughter holding the LPA insists on admitting him and administering the IV antibiotics. What will be the most appropriate course of action? Here, the patient has the full capacity, they have full mental capacity, they are telling it. So you are just agreeing to the what the patient wants. So you need to stick to what the patient wants. You're not going against what the patient wants here. So you need to respect the patient wishes, discontinue the active treatment, and arrange the palliative care at home so that the last few days what the elderly person is having can peacefully spend with the relatives. A teacher finds a suicide note written by child and is concerned for child's well-being, refers child to the emergency department. The child's father recently passed away, but the child expresses that he feels fine and wants to return home. What is the most appropriate course of action here? Here, you need to refer urgently to the camps. You're worried about the child here. Child will always say, I am fine, I want to go back home. But the thing is, suicide note is there. So it isn't planned thing what the kid is doing. He's planning to kill himself, planned thing. And there is a triggering agent also. Grandfather has died. So he's in that depression where he is planning to kill himself. That itself says that urgent CAMS referral is required. Admit and CAMS referral. You want the CAMS to see the patient in the emergency department itself. That's why we are doing an urgent CAMS referral. Admission is required or not required. CAMS will decide what next to be done. That's why option number 3 is most appropriate. Discharge, you cannot discharge, you cannot discharge, you cannot discharge. Admit might be required eventually, but we want the CAMS to see this patient immediately. That is what we wanted. That's why we are choosing urgent CAMS referral over admit and CAMS referral. So that ends the SLO 7. And you have 46 days to go. We have completed the curriculum. The promise was 1 month and it has been finished before in hand 16 days before. So 46 days you have. So you have enough time to practice, revise everything and go ahead for your examination. Everything is important what we have covered. It's not that you can skip one chapter and go ahead and just go and give the exam. You cannot skip anything. You cannot say that I'll just read the important things. No, there are 180 questions. They'll cover every corner of the curriculum, what is there in your examination. There might be, if you skip a chapter, there might be easy questions coming from the chapter. Difficult questions might be coming from the chapter which you are not skipped. It becomes difficult, that more difficult for you to pass the examination. So you need to make sure you study hard, you go through all the recorded videos, you go through the complete question banks. That's when you will be getting it back. Okay. Anyone has any doubts, you can ask me. Otherwise, the class will be ending here.
Dr. Amin?
Yes, please.
Yeah, Dr. Amin, there is regarding question 75 that FGM, and that in the exam they mention that patient seen by nurse but not assessed by you. So the first step of priority to assess by yourself and before they inform the police, or direct once the nurse inform you, you're going to inform the police.
What you gonna do? Are you allowed to do an genital examination in an suspected female genital mutilation?
Even we didn't see the patient.
Yes. So basically, you're telling me whether I need to examine the patient first or inform the police.
Yeah, exactly.
Yes. You cannot examine the patient in a female genital mutilation. It is absolutely no, because you are not a forensic medical officer. Okay.
Ah,
Same thing holds good in a rape case also. You will not do any examination for that patients. You are not a forensic medical examiner here. That needs to be done by the forensic medical examiner here. It becomes a legal case here. That's why you are involving the police. The police will get their own doctor, forensic medical examiner, and he will do it.
okay, thank you to clarify. Thank you.
Sir, excuse me, one question, please.
Yes, please.
We discussed 75 questions, but on the website it's 35. The questions will be updated, the number?
They've already been updated. They're already there. All the questions are there.
So we don't have any further discussions up to exam, right? Correct?
Yes.
All right. Thank you.
Dr. Amin, I have a question, please.
Yes.
Yes. In Jehovah believe that one, there was a question, the child was 9-year-old. If the patient is 19-year-old with active and profuse bleeding, still refuse blood transfusion, or any adult, do we assess capacity, or is it a life-saving treatment, or we go ahead with the patient wishes?
You will always assume that patient has the capacity unless there is something in the stem of the question they are given which is suggestive of the patient may not have the capacity. For example, patient has a stroke. For example, patient has a head injury. Patient has a dementia. Patient is delirious. At that point of time, you need to check for the capacity. The law says you should always assume that the patient has the capacity.
Okay, so we assume the patient has the capacity, is still refusing the life-saving treatment.
Then he can do it. The law again says he can take a decision which might sound stupid for you. He can do it. It might sound unwise for you. He can take that decision.
He can take. So we have to follow the wishes of the patient.
Yes, if he is an adult.
Yeah. Okay. Can I have one more question if you don't mind?
Yes, go ahead.
There was a question regarding the patient has intracranial hemorrhage and the neurosurgeon refused for surgery,
Mhm,
right?
mhm.
And we planned that we go for the organ transfer, organ donation nurse. When I was giving, sorry, it is may be not related. When I was giving lab exam, in that they told if the patient family has not agree, but you think or the surgeon has told this is not for any further management, you will not admit to the ICU.
The latest guideline says that even though if there is a catastrophic injury, there are
Uh-huh.
minute chances of recovering in next 72 hours. For that reason, you need to give all the opportunity for the patient to recover for 72 hours. If still it persists in the same status, that's when you go ahead thinking of organ donation and withdrawing the life-sustaining support.
Okay, it is not related with the patient is 20 young age or old age. It is not related with the age.
It is not more relevant here related to the age per se. It is more relevant uh, whether the patient is already brain dead or not. In certain questions, we have already I have said that clearly in
Yeah,
the stem of the
patient
question, they
brain
have
dead.
mentioned it is a
Yeah,
brain dead. At that point of
yeah,
time, you can directly go ahead for an organ donation. Here, we do not know whether he is a brain dead or not. Here, he has only catastrophic brain injury. At that point of time, we
yes.
are stuck what needs to be done. His surgeon is just refusing the treatment for that point of time. After 72 hours, if he's showing signs of recovery, surgeons might take up.
Oh, okay. Okay, okay. Thank you.
In
Sir, do
FMG
we have
patients, just one second. If FMG patients needs medical management also, first step is inform police, a second step is medical. First step is always medical management. You as a doctor, your responsibility is mainly to save the person's life. Then do all things. That's why I keep telling medical management comes first, later on comes the other one. Just one second, I'll allow you to ask. I'll just recall sessions. I do not want to do another recall sessions. The main reason is if I do it in a rapid way, it will get diluted what I have discussed so far. For that particular reason, I do not want to dilute it. All the end of the classes, I have discussed all the recall questions and they are all time stamped. So you can, if you want to just go through the recall questions, you can just go to the recorded videos and directly play from the recall questions. So that will be the better approach rather than condensing it and explaining you, because in exam exactly same questions are not coming, they are slightly twisted around, so you need to know if they twisted around how to answer. For that reason, I shall not do any repeat of the recall questions, which becomes a very rapid session and it will not benefit anyone.
Sir, do we have a mock exam on your according to
Yes,
the
in
question?
further, we'll have a mock exam. There will be a mock live discussion. Okay, completely new questions will be there. 120 new questions will be there. Absolutely nothing from your recalls or anything. It's a completely 120 new questions which I have made will be given to you for the mock exam. And we'll be giving few practice questions also. This is not a mock exam, but these are kind of difficult questions what I'll be giving to you guys so that you can practice them. Around 200 or approximately 150 to 200 questions I'll be giving you. So what you have learned gets consolidated. These are difficult questions. Don't use it for any judging yourself how good you are. Okay, just use it to learn. This 120 questions is for you to judge how good your preparation is for the examination. And we will be discussing all these 120 questions are new questions. This I'll be discussing in the live sessions in coming up classes. There will be another mock exam of 90 questions where every time you give this mock exam, the questions will be changing. But these questions are from the recall questions itself, because recall questions around, I am expecting around at least 40 to 50 to repeat in your diet. So you need to be really thorough with the recall questions. If any questions comes, this one, you should get the right one. You shouldn't lose any mark at all. So what I have done is we will be some software adjustment we'll be doing. So you will be having a mock test, recall mock test. So 90 questions, new 90 questions from this recalls what we have discussed so far, which are 900 and 950 odd questions we have discussed. So from that 90 questions randomly will be picked up and you can test yourself how good you are in the recall question. So I'm expecting out of 90 for you to score 90 because we have already discussed multiple times and you have practiced multiple times. So that is the roadmap for coming up classes. I mean, coming up for you guys, which I'll be posting in the group.
Okay. All right. Thank you.
You're welcome.
I
Anyone
mean, can
else
I
have
have a
any
question?
doubts? Walaikum salam, please go ahead.
Regard question number 10.
Okay.
You have two options.
Okay, tell me.
Okay, you choose a different age of feel the contusion at different age of feeling. Contusion of different age of feeling, yeah, of non-accidental injury.
Yes.
In the first we have like a fracture of different age of feeling, not contusions. You said in the first. I think the most appropriate we choose inner thigh bruises. Am I
Inner thigh
right?
bruises is more specific for sexual abuse. They're asking for physical abuse here.
Physical abuse. For the criteria at
Sexual
the
abuse
first, you
is the
said
inner
just
thigh. Physical abuse is very unusual to have in physical abuse for the inner thigh bruises. Okay. So if you go through the what we have learned here in the
the
bruising,
criteria at the first, yeah.
multiple bruising of different ages of healing, basically we're talking about, that is also suggestive of a non-accidental injury.
That's clear. Thank you.
Dr.
Anyone
Amin,
else
I
has
have
any
a
questions?
question, if you don't mind.
I can't hear you.
Yes. Dr. Amin, about the patient, Jehovah's patient, I should check first the capacity or I should check the witness with the patient?
First, capacity or
Witness.
for what?
I think there is permission to, they're not allowed to transfuse the blood who's,
Okay. So basically, if he has the capacity and he is an adult, he can refuse any transfusion. He can refuse anything, any life-saving treatment, anything he can refuse if he's an adult and he has a capacity. He can refuse literally anything.
for children also.
Children's no. Children cannot be refused. They can only consent, they cannot refuse for children.
Okay. So I will treat the children according to the best interest or what?
Yes. See, anyone who is a child, okay, that means anyone who is less than 18 years of age group, okay, what you will do, you from less than 18 means 13 to 17 years age group, if they have Gillick competency, they can give the consent. Less than 13 years of age group, we take anyone who has the parental responsibility, consent from them. This both fellows can give and consent for an life-saving treatment or an limb-saving treatment, but they cannot refuse. If they refuse it, you will treat it in the patient's best interest.
Yes. It's okay. It's okay. Thank you.
Okay, it's clear now? Okay. Anyone else have any doubts? All right. The future plans will be posted in the groups. Thank you, everyone. We'll end the class here.